Good evening, friends, ladies and gentlemen. I think now we can start the GP's Cafe, the next gathering, the gathering for this month. I think you all can hear me clearly.
Yes,
today,
we can hear.
Right. Today we have two guests. One is really a guest speaker, and the other one is our very own family medicine trainee. First of all, I would like to welcome both speakers as well as all the participants for the September GP's Cafe of the Spice Road Movement of Sri Lanka. And now I would like to invite Supun to introduce the first speaker. Supun, over to you.
Thank you, Sankar. The first speaker is one of our family medicine registrars. She's Dr. Sudarshini Subasinghe. She graduated from University of Colombo, Faculty of Medicine, and currently attached to the Postgraduate Institute of Medicine in University of Colombo as a postgraduate trainee in family medicine. At the moment, she is working at University of Sri Jayawardhanapura. So she is going to make a very interesting discussion, actually. That is a patient, as I have heard, that is a patient which she faced a dilemma whether to treat or not to treat. So that's why we put the heading. So without taking much time, I would like to invite Dr. Sudarshini to take us through the presentation. Over to you, Dr. Sudarshini. Hello, Dr. Sudarshini.
Yes, thank you.
There's a slight disturbance with your mic. Will it be possible to adjust it?
Yes.
Dr. Sudarshani, you can start sharing the slides.
Hold on.
Okay, okay, sure.
Hello.
Yes, Dr. Sudarshani.
Can you see the screen, right?
Not yet.
Okay.
We can't see the slides yet. Now we can see it, but yeah, now we can see it clearly.
All right. Good evening, ladies and gentlemen. Today I'm going to present you a patient whom I encountered during my clinical rotation. The patient presented with recent onset tiredness. This is the presentation. She's a 70-year-old lady from Brahma. She lives with her grandson. And her reason for encounter was feeling tired for 5 to 6 months duration. So when you like imagine a 70-year-old lady coming with feeling tired for 5 to 6 months, like what are the possible diagnoses that would come into your mind? And what further information you need to narrow down your differential diagnosis.
Yes, now the
anemia.
forum is here.
Anemia.
Yes, actually, we have a list of differential diagnoses, and anemia would be like in the top of the list. Yes, that is true. So, what further information we need to gather from her history and investigation to find out whether she's having anemia or not.
Other symptoms: intermittent claudication, tinnitus, easy fatigability.
Yes, and examination also. We would like to check the stigmata of anemia, like the pallor and angular stomatitis and bursitis and fish. Yes. So, what are the other possible differential diagnoses?
Depression.
Yes, depression is also a possibility.
Hypothyroidism.
Yes, we have to consider hypothyroidism also. And what about the other apart from the in addition to the anemia, we have to consider the other nutritional deficiencies which causing these symptoms, isn't it? And the other 70-year-old lady when she's presenting with feeling tired, we also have to consider whether she's having some renal impairment. Or else the heart failure following most probably a silent MI, which is very common in elderly population? And can you all like think of about like other possible diagnoses? So Sharon, we like actually we have more like few important differential diagnosis to discuss, but we'll leave those differentials for the time being, and let's move into the next slide. For like further information that she presented. Actually, these informations will help you to narrow down your diagnosis further. She didn't have chest pain, shortness of breath, or cough, and her the bowel habits were normal. The sleep, she has like normal sleep, and she's taking a balanced diet. The 16th inquiry revealed no abnormalities, but all the system like inquiry was normal. She specifically complained about like forgetfulness for the especially short-term memory. So with this investigation, if we like move into past medical history, she had a breast carcinoma, and the treatment like completed 5 years back with tamoxifen, and one of her daughter also like passed away following breast carcinoma, and after death of her daughter, she was diagnosed to have like depression, and fluoxetine was also started, but unfortunately she couldn't complete her fluoxetine. Her husband passed away 10 years back, and she has 2 daughters. The other daughter who used to live with her, she moved to another house a few months back. And she was also like planning to sell her house and move to a place where she has a relative. So with these information, the examination, she was average with this lady, and mental state examination and memory was normal, and she was not pale. Her hydration was normal, and she's not dizzy, and she didn't have any peripheral edema. Her cardiovascular system examination and respiratory system examinations were normal. So now after this history and examination, can you like shall we discuss the possibilities and the necessary investigations for further management of this patient?
Now the forum is open for discussion. I think depression is still in the list.
Yeah,
Yeah.
And what about we can't like by the history and examination, can we like exclude the other possibilities like
And
somebody like raised hand, don't know whether the Dasanayaka, DMI Dasanayaka, don't know whether he wants to like add some points to our discussion.
Yes, but there's a slight problem. I think his audio is not visible. So I will make a chat message to him. Until such time, I would like to invite others to join the discussion.
Can it be chronic fatigue syndrome?
Yes, the chronic fatigue syndrome is also possible here. So in that case, like what are the like positives and negatives that you could like see in the history and examination, or whether you need some investigations to may confirm the diagnosis.
What about medically unexplained symptoms because of current situation?
Yeah, medically unexplained symptoms is like you can consider actually, but when you are like coming to a like diagnosis like those, especially the complaint of the feeling tired, we have to exclude the elderly, the population. The presentations are very vague and it's very non-specific, isn't it? So
yes,
in this case, yeah. So we have to exclude the disease like chronic renal failure, heart failure, and even diabetes is a possibility, hypothyroidism, and the electrolyte the imbalance, isn't it? Then because if we miss this diagnosis, then the patient will be in trouble because we the considering all these aspects and the possibility of depression also, the basic investigation were ordered, and these are the basic investigation findings. Her full blood count was normal. ESR, ECG, serum creatinine, all were normal. Even she came with a lipid profile that is also normal. Thyroid function was normal, including TSH and T4. And her serum electrolyte normal, and fasting blood sugar was also in normal range. So, like, if you like summarize, like put like all the history, examination, and investigation findings together, what are the possibilities now you have in your mind, and what are the earlier the differential diagnosis that we can exclude?
So there's no anemia, no
yeah,
hypothyroidism,
no,
and more towards the psychiatric reasons. Yeah,
Mm.
maybe due to depression, or what about the adjustment disorder because she has shifted to a new place?
Yes,
That
adjustment
is also
disorder is
possible.
also like high in the list here. So with this, the findings, these are the like the differential, like the most probable diagnosis. These are the likely causes at that moment I considered. I thought this could be a normal response to a stressful life event because her one daughter moved to to a like a new house, and she's like living along with the grandson. And the other thing is like other thing was because of the corona epidemic, they are like helper was also not there at the home. So that could bring an additional stress workload to her. Like being a 70-year-old lady, that will be like a great stressful event to her. And adjustment disorder was also a possibility. And since she had a like past history of breast carcinoma, and she's worried about like her grandson now who has lost her mother. So anxiety, especially with regard to her health, may be also there. And she may be like, since she's 70-year-old, the age-related wear and tear may be like bringing her the like tiredness. But the depression was also like we have to consider it seriously, because she was earlier diagnosed to have depression and started SSRI, but unfortunately she couldn't complete the treatment. So the depression is most likely in that kind of history. And the other possibility was the emptiness syndrome, because she has the house her daughter left, and the servant also left, and now she's alone with the grandson, and she's also like planning to move to a new house where neighbors are there. So that means she wants some relatives and friends to talk about. So the leaving of her daughter may have caused a vacuum in her life. So that would lead to emptiness syndrome. The organic pathology, like the earlier discussed causes like chronic renal failure, heart failure, all were like very unlikely with the about the investigations finding. And she complained of dementia. So earlier I considered the dementia also, but with the mental state examination, it was also not a possible cause, but the memory loss could be a pseudodementia. That is also a feature of depression, isn't it? So, with this, how we are going to patient, whether you are like going to, because she doesn't have like classic features of depression. So in that case, and other possibilities are also there, the adjustment disorder and emptiness syndrome and stressful life event. And I think somebody suggested that the unexplained medical symptoms and chronic fatigue, like considering all those possibilities, how we are like going to, how you think the most appropriate management would be?
Regarding depression, did you just inquire about this classic, say, not the classic, actually, PHQ-9, the main 9 symptoms?
Yes, I specifically, yeah, because she has a past history that she revealed. I specifically asked about the like enjoyment and the lack of the appetite problem, and the everything, the all the depression symptoms I asked, and she didn't have even like. In fact, she was with a very good understanding of the like reality of life, and she was like her religion was Buddhist, and like very rational with the religion also. So she told me that whenever like she feels some negative things, she like just relate those things to the religion, try to overcome those feelings. So actually, I couldn't find any feature of depression.
What about screening for anxiety?
Sorry?
What about screening for anxiety, generalized anxiety disorder?
Yeah, the anxiety is also a possibility, but actually, it is a possibility. But the other like the physical symptoms of anxiety, like palpitation, sweating, tremors, those things were not there. And at the same time, the psychological symptoms like anticipation, like she's like always like worrying thoughts, all those were also not there. So anxiety I the in that even though the anxiety is a possibility, that the depression, the emptiness syndrome, and the adjustment disorders are high in the list.
And the fatigue was for about 6 months, right?
Yeah, 6 months.
Now, when you take these possible diagnoses, I
Yes.
mean, almost all are not related to any physical disorder.
Yes.
So now we have to probably now, rather than trying to say definitely understand what is the disorder, I think now we have to probably go for a management plan, right?
Yes.
Because even when you take the disorders we have mentioned here, for an example, adjustment disorders, empty nest.
Yes.
So most of the things, and even those things would have the other symptoms, and I mean, they are overlapping the symptoms, and
Yeah.
yeah.
So that is what like I actually what I did was I explained all these things to her, the possibility of like psychological elements in her the complaint. She also like agree because she has past experience with the diagnosis of depression, and she know that she was prescribed a drug which she couldn't take. So then I told her that we have an option of restarting, like starting the same drug and see whether she feels some improvement. And actually, she was like very happy to start because she herself told that yes, I could have taken the drug earlier, but I couldn't. So, and since like she was also like very keen to take the drug, and I was also like the in my differential diagnosis, this the depression was also in like top. So I thought of I will start her on SSRI, and at the same time I explained her the non-pharmacological management like relaxation, exercise, those things also. And I started on SSRI, that is fluoxetine, 20 milligram Manian. That was my management at that point, and I asked her to come in 2 weeks for review. I don't know whether like would you all like any other suggestions for the management?
How's her sleep? I'm just asking because fluoxetine is well known to like cause insomnia sometimes, right?
No, her sleep was normal.
Right. What about starting something like sertraline? I'm just asking. I mean,
Yeah. Actually, that was also a possibility because I started fluoxetine at that moment because earlier she was given fluoxetine.
Exactly. Yeah.
She was very familiar with the drug also. That's why I did, because she was like little anxious about taking drug also. That's why she has not taken at the like earlier episode. So I thought, and like by talking to her, I realized that she was like little familiar with the fluoxetine. That's why I started fluoxetine, but of course, sertraline would be a better option considering the side effect profile.
And what about counseling?
Yeah, actually, like counseling, I actually during that first encounter, I started this drug and I advised her on the non-pharmacological treatment, and I plan to arrange the counseling session also. Like after discussing with her, because she was already like participating in religious program, meditation program, and those kind of things. And like she told me that whenever she met her like relations, she used to talk with them. And actually when she's like leaving, she told me that, yes doctor, I feel that my tiredness mainly in the like situations where I am alone. When I'm with my friends and relatives, I don't feel tiredness. That is also like very much of suggestive of depression.
What about family counseling?
Family counseling means she has only grandson who is like schooling. Uh, husband is like passed away, so but we can
The
consider.
daughter who left the
Yeah, that also like should consider.
what was the HB like?
HB was normal. It's
So,
like around 12 years.
What about the course of vitamin D?
Actually, I discussed with her regarding like the possibility of vitamin D deficiency, but she was, she used to be in the like sun, like she used to like do gardening and like cleaning the garden early in the morning. And anyway, I advise her the importance of like exposure to the sunlight, considering the possibility of vitamin D deficiency. But actually, I didn't think at that moment she's in the like there is the like absolute indication to check her vitamin D level.
Very interesting. Now, what happened next? Or did you have a review or
Yes, actually, that was like also like it was also like interesting. After 2 weeks, when she came, and when I asked about the drug treatment, unfortunately, she has not taken the drug. But she told that like because she was like little, even though like I explained the like with great detail about the drug and the importance of continuation of the drug. Unfortunately, she has not taken, and she told that doctor, I don't feel that I need that drug because I feel that I have like I need to do some other psychological things like the meditation and those kind of things. And then I told since she at that moment also I reassessed her for the especially the self harm and suicidal ideas and severe depression. Those symptoms were not there. So then I said that, oh, it's okay, but keep in mind that there is a like possibility of like getting a help from the drugs also. And I asked her to like come back for another review in 2 weeks. Unfortunately, like I changed my appointment, so I didn't meet her after that. Anyway, the other my colleagues, they will definitely will see and do the necessary him.
Any other questions from the audience?
Other than the meditation, was she involved in any other specific activities? I mean, for herself?
I mean,
No, obviously this need, like she probably needs a lot of psychotherapy because she doesn't take she's not taking the medication. So how did she keep herself occupied throughout the day? Like other than you mentioned about the meditation, what else was she advised to, you know, do more activities to keep herself occupied or?
yeah, because when she presented to us, she didn't have the helper.
Okay.
So she used to like cook for her and her like grandson, and she used to do all the house chores. And the other thing is, I advise her regarding the exercise plan also, and she agreed that she told that she can find time to do walking.
Okay.
What about taking a second opinion from a psychiatrist?
From my
And what is the place of CBT if you are treating as depression?
yeah, that can be considered, but at the if you like to see the patient, like the patient is like she's like look healthy, and the mood and everything was like normal. So at that moment, I didn't realize, I didn't see the whether I didn't see the necessity of a second opinion. But of course, if she like continue to have the problem, and if she is not willing to take the drug, we can consider a proper referral to a psychiatrist to arrange the cognitive behavior therapy.
Yeah, I think that brings the interesting discussion on referrals and all. Anyway, sorry. Anyway, I think here, as you told, there was no danger sign. One, and then if after repeated presentations or visits, still she feels the same, I think we can refer. But at this moment, I thought. I also think that it's not necessary to refer at the first instance or first or second instance, because I think if a qualified general practitioner can definitely handle such situations, because most of now we understand most of the presentations have some sort of a psychological aspect, and most of these things, even which presents with say symptoms, physical symptoms, more intense physical symptoms are more psychologically related. So I also thought at this moment there is no necessity to refer.
And even if we refer, sometimes they also might start drug therapy, antidepressants. So
I think if
what's
the
the
patient will not taken, ended up in the same, because sometimes patients are like more happy to be with the family physician rather than
actually it is not sometimes. I feel like it's always.
Most
They are
of the
happy
time.
to, because I have seen many instances, even when we refer, they come back with the prescription and ask from us whether to take it or not.
yes, that is happen, like it happened all the time.
I would just like to add on something.
Yes.
What ma'am has done is absolutely right. As a general physician, we can very comfortably treat patients with mild to moderate depression. Only when the symptoms are at the higher level, and only when there is any intention of self-harm, that is when we need to make sure that these patients are referred to a psychiatrist for inpatient care and for further close follow-up also. Also, one more thing to note is, as family physicians, we are able to definitely give them more time than the specialist. What happens is, when we, at the first instance itself, refer them to the specialist, they might not have the background of the patient, how much we have, or they might not be able to give them more than 2 or 5 minutes. The drug therapy would be definitely adequate, more than adequate, but the time and the connect that a family physician can give makes a whole lot of difference for the patient as well. And about cognitive behavioral therapy, CBT, a psychologist who's doing counseling can also give them CBT. For CBT alone, we don't have to necessarily send a patient to a psychiatrist.
Excuse me, can you introduce yourself? Is this from Pakistan or India?
My name is Dr. Anupama Menon. I'm from India, Bangalore, India.
Okay, Anupama. Yes, I know you. Okay.
Yeah.
Any other suggestions or questions? Because we have to move to the next presentation also. So before that, any suggestions from the audience? Well, in the absence of further suggestions and discussions, I would like to thank Dr. Sudashini Subusingha for the nice presentation and
Thank you very much for you.
provoking the discussion and helping us to decide whether to treat or not to treat when we meet a patient like this. And while thanking Dr. Sudashini, I would like to invite Sankar to introduce the next speaker. She is a guest to our country. And Sankar, over to you.
Thank you, Supun. Ladies and gentlemen, we have Dr. Kinle Bhuti. She's my good friend from Bhutan, and very importantly, she's a prominent figure in Bhutan not because of anything else. She's the first trained family physician or general practitioner in Bhutan who just finished her postgraduate thesis and got the qualification. So she would be the pioneer, one of the pioneers of family medicine in Bhutan, and she's also the chair of the Spice Road Bhutan, the Young Family Doctors Movement, and also she's the Aspire representative of the Spice Road South Asia. So,
Hello, good evening.
Good evening, Kinle. You can share the screen and start.
Okay.
Thanks for joining.
Okay. Just give me a few seconds.
Kinle has been instrumental to the Spice Road South Asia because she is now preparing a module on leadership. So this time she's going to talk about the general practitioner or the family physician's approach as a team leader and also as a community leader. So everybody leads in a practice, and also how that team can be led by a family physician and also as a community leader.
Just give me a few more minutes. Okay.
You can now, I think, now your screen is very much visible. You can now start the presentation, Kinley. Yes.
No, I'm not able to share my presentation.
Okay, we can see general practice in Bhutan. This is the.
Okay, yes.
Yes.
Okay.
Okay.
Can you see that?
Yes, yes, yes. We can see your dragon.
Okay. Okay, then thank you. Good evening, everyone. Thank you for having me here. I feel very privileged to be part of the GP Cafe in Sri Lanka. And also greetings to all the listeners over the region. As already introduced by Sanka, my name is Kilebuti. I'm the first GP product of Bhutan. There, my seniors are all being studied from India, either India or Nepal. So I'm the first GP student who is truly made in Bhutan. I did my MBBS from Bangladesh in Chittagong Medical College. That's a brief introduction of myself. So I'll be taking you through the GP practice in Bhutan, the role of general practice in community, how we lead the community. Hello?
Yes, Dr.
Yes,
Kinley, we can
go
hear.
ahead.
We can hear.
Okay, sorry. So just briefly introducing about my country. Bhutan is a small country, you know, sandwiched between India and China, the two largest country. And it's a very small country with a total population of about 7 lakhs only. And the medical doctors we have is only 376. And these are the brief, the number of health workers in my country. And then just taking you through the number of hospitals or the health facilities in Bhutan. We have 49 hospitals in the country with the primary health center, sub-post, even outreach clinics in our country. So, but then we have only one tertiary referral hospital that is located in the capital city. So taking back into the history, so GP initially was not there in Bhutan. So it was initially it started as a flu clinic in 1990s, which were mainly manned by all the clinical officers. They were the diploma holders, and then they functioned like 12 hours divided into 3 shifts. And later it was only in 2014 that the general like OPDs were actually manned by the general practitioners and the medical officers, and hence all the general practicing happened since then, like in a very effective way, and had been contributing a lot to the country's primary health care. So the role of the GP is usually to manage the general patients, both adults and pediatrics. And we also refer the patients, like as being discussed in the previous cases by the first presentation. We treat the patients, and if we need a further referral, then we refer to the appropriate specialized OPDs. And we also do triaging and then treat patients in the evening clinics, in the government holidays, and also like when there is a national parliament duty going on, then it's the role of the general practitioner to provide the service. So in the community, we usually lead in the programs like health promotions in the mother and child care, healthcare, the dietary habits. We focus on the dietary habits and hygienes. We also do biennial school health screenings. And then we also do screening for the elderly people for the non-communicable diseases, and for women for the cervical cancer. So this is in one of the school visits in Bhutan, in the most furthest district of Bhutan. Though Bhutan is a small country, because of the being landlocked, it's like it takes so many days to travel to one part of the country to the another part of the country. So this is me providing school health screening to the school, one of the remotest school in one of the district in Tashiangti, which is about 600 kilometers away from the capital city. So on my right, this is a small 7-year-old boy who had been staying aloof from his friends all his life, that is the 7 years of his life, because he was not able to run or play with other kids as he was getting easily tired, and he had this syncopal spells. So when I checked, when I went for the school screening, I found that there was a cardiac murmur, and then I later referred to the tertiary hospital in Thimphu, and he was found, after doing echo, he was found to have atrial septal defect with the pulmonary atresia. He was later referred, because we don't have a cardiothoracic surgeon, he was referred to India for cardiac catheterization. And on my right, there's a 9-year-old girl who barely looks like a 5-year-old, is a stunted growth. There are various social issues and nutritional problems that the child faced. So because of that, she had a stunted growth. So in the preventive health programs, we usually go for these NCD screenings like diabetes and hypertension, because the people, mostly our farmers, they don't have time to visit health. They don't seek health service unless they are really sick. So it really gets delayed when it comes to the non-communicable diseases. So what we do is, because we have all the basic health unit and outreach clinics, we make an appointment to visit all these, even the furthest of the villages in my country. So we usually promote on the non-communicable diseases, STI, especially HIV, and tuberculosis and Hansen's disease also. So not only that, we also be an example in a community. We just don't command our co-workers to do it. We actually go and work with them, because we believe that a team is better than an individual. So we always work in a team, and then be an example by being punctual, reliable, and trustworthy. And we care for team members like we care for our family members. So in the role of GP in the present pandemic situations in my country, presently we have 238 confirmed cases of coronavirus, and luckily we don't have any deaths. And then active cases are of 83, and we recently just our country had a relaxation after 21 days of a national lockdown. So here also the GP mans all the flu clinics all over the country, and under the command of His Majesty the King, all the flu clinics are built away from the hospitals to protect the hospital from being shutting down from the COVID situation. So it is always away from the hospital, like it's near but away and in a clearly open spaces. So this is in helipad right below the National Referral Hospital in Thimphu. So the GP plays a role in screening all the flu cases. And then recently we just found that there was one case of coronavirus without any travel history or contact history being particularly detected from the flu clinic. So this is the flu clinic, some of the flu clinics in the districts and in the capital city of my country. So that comes to the end of my presentation. So take-home messages is to keep learning, keep inspiring, keep leading for the better society. So currently in my country, for the global pandemic, our king is leading the fight against the coronavirus, and our prime minister, who is also a doctor, a surgeon himself, is also in the front line fighting for the national novel coronavirus. Thank you. Any questions? Hello?
That was a nice presentation, Dr. Kinley. Thank you.
Thank you.
Kinley, tell us how the preventive sector of Bhutan goes ahead.
The preventive. Okay, we go for this the villages visit like to screen for the NCDs. Like we check their blood pressure, we give them the blood tests for the diabetes, and we also like focus on the health, the hygiene and the dietary habits, because our people, some of them are in a very high altitude, so most of them doesn't know about the balanced diet. And then most of our diseases, like example, like the stomach cancer is one of the leading cause of death in my country, because our people are like mainly consuming the diet, because it's in the high altitude, so they cannot grow much of the fresh vegetables. So what they believe is, they believe in dyeing like the vegetables and all, in consuming it like almost in a very unhealthy way. So we focus in this thing, in the diet, in the hygiene, and also in like for the women health and the mother child health. Like we focus on the mother to have institutional delivery, and to always visit the nearby hospital or the outreach clinic if they think they are pregnant, so that we can provide them with all the necessary ANC supplementations. Did I answer your question?
Yeah, with regard to immunization and
Yes.
maternal health, is that so? This is led by GPs or what?
Yes, even immunization, because like I said before, like our country is a very landlocked country, so people, they don't come to visit health facilities unless they are really sick. So knowing that, we always make a schedule that we take note of all the reproductive age group people, you know, and then we on our visit, on every visit, we take note of if there's any pregnant women, if there's any old elderly people, if there's any newly diagnosed, then we take note, and then we like in the outreach clinic, we visit them, and then even immunize the kids at the like every fortnight. So in some babies, their vaccination might be delivered by 2 weeks, because we visit in the outreach clinic every 2 weeks. But then every child is being covered. We ensure that every child is covered of all the immunizations and all. Hello?
Yes, Dr. Kinley.
Yes.
Sanka and others, are there any questions?
Yeah, Dr. Kenley, congratulations on your good work at Bhutan. My question is, in the recent past, it has been, you have reached the lowest percentage of rural sector compared to your history. Is there a difference in disease presentation when you compare the rural and urban areas of Bhutan?
Yes, thank you very much for the question. So comparing to like the urban and rural area, the disease burden is more in urban area, and also the burden of non-communicable diseases like related to lifestyle, like hypertension and diabetes, are also more in urban areas, whereas in the rural areas, like I said, the access to processed food or the fresh vegetables is not there. So also they have to like really earn their daily bread by working tirelessly. So usually there are not much of hypertension and diabetes being diagnosed there. But like I said, that because of the diet related to the dry diet, smoked food and all, we do have more of cancer patients, tumor patients coming from the rural areas, and like compared to the diabetes and hypertension. And also some of the congenital diseases are in the urban, it's more like pronounced or being diagnosed, whereas in the rural area, unless we go and see them, it's not being detected. So that is one difference. So by the time, if we are delayed in our visit to the rural areas, then there is a little bit of delay in the treatment in that sort of like congenital diseases. So that's the difference.
Thank you, Candy.
Thank you for your question.
Are there any more questions to Dr. Kinley? Well, in the absence of any more questions or suggestions, I would like to thank Dr. Kinley for joining with us today and making such a nice presentation. And I would like to thank Sanka for introducing her to this forum. And we hope that all of you who joined today will be in touch with us in the future because we are planning to organize the GP's Cafe at least once a month. So, Sanka? Yes, I think Sanka has dropped out. Anyway, so thank you all for joining us. So we will meet next time.
Yes.
Thank you.
Thank
all.
you. Thank you very much. Thank you.
Yeah,
Good.
welcome.
Bye-bye.
Bye. Good night.
Good night. Bye.